that one test changed TB diagnosis forever. Any idea what is that? It's CBNAAT. But is it enough? Let's decode TB diagnosis step by step. So, hello everyone, this is Brainless Medico and I am Dr. Manoj, and today we are going to learn a very important topic in the playlist, diagnosis of tuberculosis. Very important 5 marker. So, let's dig into it. Very important 5 marker. So, let's dig into it. Diagnosis of tuberculosis: when you suspect a TB, cough more than 2 weeks, right? I'm discussing from first video. Cough will be more than 2 weeks. Fever with evening rise, even I explained this. Weight loss, night sweats, hemoptysis, TB contact or HIV. TB is the one of the, like what you say, most common opportunistic infection of the bacterial infection caused in HIV and even diabetic patients. Why? Any idea? Due to suppressed immunity. And as I said, TB is all about immune suppression and your hypersensitivity reaction. Always think TB first in India if any of these or almost all symptoms seen in TB. Then coming to diagnostics tool, we have microbiology evidence, most important. Then we have radiology. Then we have supportive test. So sputum examination, it comes under what? Microbiology, right? Acid fast bacilli. We'll be doing ZN stain. You people are going to do like ZN staining in second year, and one of the irritating practical session. So I'm not digging into my practical experience. So we did ZN stain, nothing deep into that. Then coming to why we are going to do it, because it detects the acid fast bacilli. What is the advantage of this test is like it is cheap and fast, so it is still now practiced. What is the limitation is need high bacillary load as usual. Like if it is cheap and fast, we are not going to detect a small quantity of bacilli if there is present. So we have to go with a better test. If there is a high bacillary load, then we can. Otherwise, like cannot detect if drug resistant cases are there. Then coming to CBNAAT, it's a gene expert. One investigation changed entire diagnosis of TB era. So CBNAAT. Don't run into full form of the CBNAAT and all. Just remember CBNAAT. Mycobacterium tuberculosis will be detected from it, and rifampicin resistance cases. Even I said why ZN stain is least used in than CBNAAT, because it has a limitation where resistant cases is not able to detect it. So CBNAAT is in the upper end comparing to ZN stain. What are the advantage? It's rapid, within 2 hours, highly sensitive. Then limitation, there has to be some limitation, so that we went to the next upgrade. Limitation, does not detect resistant to other drug. So what is the difference between ZN stain and this is, ZN stain does not detect any of the resistant cases, but CBNAAT can detect rifampicin, whereas other drug resistant cases are not detected from CBNAAT. So test of choice for initial diagnosis is CBNAAT. So just take it as a screening. We can take it as screening. Then coming to confirmatory test, LJ medium, it is green color. 4 to 8 weeks it will take. Then MGIT, it will take 1 to 3 weeks. It is a gold standard used for drug sensitivity testing, even for treatment failure. So at last, which is a gold standard? It's a culture medium. Then coming to chest X-ray, what we are going to see in common finding: upper lobe infiltration, cavitation, as I said, fibrosis, hilar lymphadenopathy in primary TB, then pleural effusion. X-ray supportive, not confirmatory. Remember, what is confirmatory? You have to go with a culture or CBNAAT. Then coming to other test, Montauk's test shows exposure, not disease. Positive in latent TB, BCG vaccination. So it will be false positive in BCG vaccination. So you should be careful before testing this Montauk's test in children when there has been underwent BCG vaccination. Then IGRA measures interferon gamma release and not useful in active TB diagnosis. Then diagnosis of flow, suspected TB, sputum for CBNAAT. If positive, start treatment. If negative but suspicion high, then you have to continue with a culture or imaging to confirm your diagnosis. Then coming to extrapulmonary TB, samples from affected site. We usually collect CSF, pleural fluid, or even lymph nodes or FNAC. CBNAAT preferred. So examples, we have CBNAAT first line test, rifampicin resistance surrogate marker for MDR TB, multi-drug resistant TB. We'll be talking this in detail in further sessions. Culture is the gold standard. Montauk's test is not useful in active TB. So In this video, we learned how we are going to diagnose TB. Then diagnosis decides treatment. So we will break down TB treatment regimens without confusion in further videos.